No.
Okay, shall we get underway then? Well, good afternoon, everyone. It's great to see such a great turnout for the Cross theme seminar, and we're delighted to have two excellent speakers with us today. So we're going to hear from Ruth Dundas first. Ruth is based in the Social and Public Health Sciences unit, and today she's going to be talking about the health impacts of a voucher scheme for low-income mothers and children, an evaluation of the Healthy Start Voucher Scheme. So thank you so much, Ruth. I'd encourage people, there will be time for questions at the end, but you might want to pop your questions in the chat too, if you wish. All right, thank you. I'll hand over to you now, Ruth. Thanks.
Thanks, Katie, and thanks for inviting me to present today. As Katie said, I'm going to present an experience of evaluating a policy in the UK that provides vouchers for low-income pregnant women and mothers. And I'll start with some background.
To interrupt, we're not just seeing your main slide, we're sort of seeing the next slide as well. I don't know if you want it set up like that or if you'd rather we just see your main
slide. Let me stop sharing. I have no idea what has happened.
Has it gone a bit weird?
We're in presenter view rather than normal slide view. That was what the problem was.
Let me start sharing again, and I don't know. You'd think by a year of doing this, I would know what I'm doing. Sorry, everybody.
Totally fine. Okay.
Can you see it?
Yay, that's it. That's it now.
Slide now.
Yeah, very good. Sorry to.
No, that's okay. So, as I say, I'll start with some background as to why it's important to have interventions and policies in the early years, and also why it's important to have evaluations of such policies. And then I'll describe our attempt at an outcome evaluation of the Healthy Start Voucher Scheme. So having a good start in life during pregnancy and also infancy, that's been shown to be important for both living a healthy life and a longer life. And health and well-being during the early years, which starts sort of pre-conception, has a crucial impact on chronic disease and inequalities across the life course and also from one generation to the next. For example, there is evidence of the impact of intrauterine and infant growth and preterm birth on cardiovascular health. And the determinants of infant and child health, we know that they're complex and they're all interrelated, and they range from family socioeconomic circumstances, childcare settings, through to neighbourhood deprivation and things like pollution. The First 1,000 Days initiative, this was a concept started in 2010 by Hillary Clinton, and it was actually an international conference on global child nutrition. But it has influenced health policy in high-income countries, including the UK, and there was a recent UK parliamentary review that took evidence about it. And really the idea is that the first 1,000 days, so from conception right through to the age of 2, because it's a period of rapid growth, what happens during this time lays the foundations for future health and development. And that's maybe not new for people in the area of infant and child health, but recently it's had more traction because Michael Marmot had it as one of his recommendations in the Commission for Social Determinants of Health to focus on early years. James Heckman, who's an economist, if you look on the bottom left of the screen, this is known as the Heckman curve now, and that shows that the highest rate of economic returns comes from the earliest investment in the life course. So you can see the graph has return of investments on the y-axis, and going along the x-axis it's age of child. And you can see that the economic benefits of investing early is greater, and then also throughout childhood, and that provides sort of more success to more children and therefore greater economic productivity and reduced spending for society as a whole. So there is a willingness of governments to invest in early years, and we know that many governments, not just the UK governments, have strategies and policies in place. And there have been some evaluations of early years policies. So in Manitoba in Canada, they had a programme for low-income pregnant women and then for their children. This had minimal effects on outcomes, but some positive benefits for one of the subgroups. In Sweden, they evaluated the Salute programme, and this looked at the effectiveness of a universal sort of health promotion and health visitor intervention. And they found limited immediate positive impact on the child and maternal health outcomes, but they are going to continue to follow them up to look at longer term outcomes. In Scotland, they introduced a baby box for all newborns, and you can see the picture there shows the sort of contents of the box, and it contains things that are needed in the first few weeks, such as nappies, nappy bags, baby grows, etc. Now, this policy has been in Finland for about 80 years, but nobody knows the effect on health outcomes. And also in the UK, there are other policies in place, such as the enhanced provision of early years childcare, the Healthy Start Vouchers, and there was a previous universal policy called the Health and Pregnancy Grant. So, as I said, there's a willingness to invest in policies with the aim of improving these kind of early years experiences. But how do we know if these policies are working? There have been a few outcome evaluations of these policies, but not many. And that is despite the House of Commons report on health inequalities, and that was published in sort of 2009, 2010. And they state there is an ethical imperative to develop and use evidence-based policy. And they go on to talk about these are experiments on the public and there could be unintended effects. And they say such wanton large-scale experimentation is unethical and needs to be superseded by a more rigorous culture of piloting, evaluating, and using the results to inform policy. And they also sort of carry on and bemoan the fact that when evaluations are done, they're usually process evaluations and not really the outcome evaluations. So on the background to all of that, we decided we would evaluate the Healthy Start Voucher Scheme. Now, the Healthy Start Voucher Scheme was introduced in 2005, 2006, and it grew from the Welfare Food Scheme, and the Welfare Food Scheme provided low-income pregnant women milk tokens after the Second World War. There are four main aims of the Healthy Start Voucher Scheme. It's to improve the nutrition of pregnant women, increase fruit and vegetable intake, initiate and maintain breastfeeding, introduce foods in addition to milk as part of a progressively varied diet when the infants are about 6 months old. Oh, and I should have said that it's a means-tested voucher scheme. So if women, the pregnant women and mothers with children under 4, if these women are in receipt of certain means-tested benefits, then they're eligible for these vouchers, and these vouchers can be spent on milk, infant formula milk, and fruit and vegetables. The vouchers are worth £3.10 a week, and they can be spent in all the range of shops, going from large supermarkets right down to neighbourhood shops and pharmacies. And it's estimated to cost the UK government about £150 million per year. And it's not been, there have been some evaluations I'll show you about the kind of process of it, but it's not really been evaluated in terms of health outcomes. And one sort of reason is it's been quite difficult to identify comparison groups. Who would you be comparing these low-income women to? So as I said, the effectiveness and the sort of cost effectiveness of the Healthy Start vouchers hasn't been shown yet, but there was a previous small study of about 300 women who compared the Healthy Start vouchers to the Welfare Food Scheme. And they found that mothers eligible for the Healthy Start vouchers had a higher daily intake of iron, calcium, folate, and vitamin C than the mothers that were eligible for the Welfare Food Scheme. And also actually 3 months postpartum, the Healthy Start voucher mothers also reported higher iron, calcium, folate, and vitamin, as well as higher consumption of fruit and vegetables. There was a mixed method study of practitioners and low-income mothers. And again, this was more a kind of sort of process evaluation. So like, how did they find the scheme? Did the scheme work for them? And they found that the recipients did value the vouchers, but there were barriers to access, including low levels of awareness of the Healthy Start vouchers among both mothers and practitioners, and there was uncertainty about eligibility criteria among the health professionals. And again, there was a report on the kind of operational aspects of the Healthy Start voucher, and that addressed issues of kind of eligibility and uptake, and how the vouchers were exchanged and how the shops managed to claim the vouchers back. So again, this was more about the kind of like the operational aspects rather than any kind of like outcome evaluation. And that report concluded that a comparative study is needed to assess the effectiveness and cost effectiveness of the Healthy Start voucher scheme. So the aim of this piece of work was to evaluate the Healthy Start voucher scheme. So does it improve the nutrition of pregnant women and the health outcomes of their infants, and is it cost effective? There were 3 parts to this evaluation. There was a secondary analysis of 2 existing data sets. We also did a qualitative interview study of mothers and an economic analysis to assess the cost effectiveness. But today I'll just focus on the secondary analysis of the 2 existing data sets. So this will be, we're going to evaluate it using natural experimental methods. And what we mean by a sort of natural experiment is that the exposure to the intervention isn't manipulated by the researchers. So the researchers don't have any control over how the people are exposed to the intervention. This is a policy that's in place. People are receiving the vouchers already, and us as researchers don't have any opportunity to assign the vouchers or see how the policy is rolled out or is run. And as such, there isn't a possibility to do a randomised control trial or any sort of pseudo-randomised design. There's no random allocation to the to receive the vouchers. You receive the vouchers if you're eligible. As I say, the policy is already in place, and it's not obvious what a control group would be. Although we did, you'll see later, manage to find some. There are eligibility criteria for getting the vouchers. So the woman needs to be 10 weeks pregnant or have a child under the age of 4. So it's from 10 weeks pregnant right up until your child is 4. The women need to be on income support. So this was in 2010, and you'll see later the reason that we needed to look at 2010 is because that's when the data sets were available to look at birth outcomes. So things have moved on in terms of welfare benefits since 2010, but in 2010 they needed to be on income support or income-based job seekers, or the income-based employment support allowance, or the household must have had an income or needed an income of less than £16,000. And there are new rules now for universal credit, but these were the eligibility criteria that we were using for this study. So we've talked about control groups, and this was our idea of identifying a control group. So this diagram represents a sort of population of pregnant women and mothers and how they relate to Healthy Start vouchers. So we have got a group of women who are eligible and claim Healthy Start vouchers. So they're in the darker green box, they're the recipients. So they're eligible, they meet the eligibility criteria, and they claim the vouchers. And we've got a group right next to them in the lighter green box. They're eligible for the vouchers, so they meet the eligibility criteria, but for some reason they don't claim the vouchers. They might not know about them, they might not want to claim them, for some reason they don't. They're the ones who are nearly eligible. And they might have a slightly higher household income, so they're not actually eligible. They don't meet the eligibility criteria, but they're very close to meeting the income criteria, so they're nearly eligible for the vouchers. So the circumstances are quite similar to the eligible women, they just differ a little bit on whether they meet the eligibility criteria. And then there's a wider group of women who are in the rectangle, and I've called that the rest of the population, and they're very far from the eligibility criteria. So you'll see how that diagram relates to comparison groups on the next few slides. So we've got 3 different groups of people, and then we can make comparisons based on these groups. So we've got our main group is the recipients of the Healthy Start vouchers. So this is about the dose of the Start vouchers. So we've got recipients and we can compare them to the eligible group. So the recipients are the green group, the darker green group, they're eligible and they claim the vouchers. And then we've got the paler green group who are eligible but don't claim them. So we can compare those two groups. We can also compare the recipients to the nearly eligible group. So the people who get the Healthy Start vouchers against people who are not quite eligible for the Healthy Start vouchers. And then we can do, which sort of represents an intention to treat analysis. So this is how the policy is kind of working in practice. We've got all the eligible groups. So if you're eligible, so the two green groups, we combine them and compare them. So they're combined, they're eligible for Healthy Start vouchers regardless of uptake. This is how the policy is kind of working in practice, if you like, and we can compare them to the nearly eligible people, the ones who just miss the eligibility criteria for Healthy Start vouchers. So in summary, we've got the three comparison groups. We've got treated versus eligible but not treated. We've got treated versus nearly eligible, and we've got the eligible versus nearly eligible. But there's still a concern because the mothers are not randomly assigned to these groups. So how do we ensure that we're making fair comparisons across these groups if we're wanting to look at the kind of causal effect of the Healthy Start voucher scheme? So we can use propensity score matching, and that's really what a propensity score is. It's the probability of being assigned to a treatment, and that's conditional on the observed baseline characteristics. So this method kind of tries to mimic the characteristics of a randomized control trial when you can't do a randomized control trial, but you do have other data that you know about people. So the propensity score is a sort of balancing score, and that really means that if you condition on the propensity score, the distribution of the observed baseline covariates will be similar between treated and untreated subjects. So I suppose in other words, there's lots of in other words, this matching on these key characteristics can allow for the groups to be more balanced on covariates. And really it's a technique that can minimize selection bias, and it's really better at getting to the causal effect than simple covariate adjustment in the models. And that's the list of the covariates that we used to match the groups. We matched on mother's social class, education, family type, whether the child was the firstborn or not, the mother's age, SIMD, which is a measure of area deprivation, and for the Scottish sample, the Scottish Government Urban Rural classification. We're using two data sources. We're using the infant feeding study from 2010. Remember I said that the eligibility criteria in 2010, so because we're using the infant feeding survey, the most recent one was done in 2010, and that's a UK-wide survey, so it's representative of UK births, and we're using the Growing Up in Scotland Birth Cohort 2 data. Again, that was the children were around 10 months in 2010, 2011, and that's representative of Scottish births and can be linked to routinely collected data, so like hospitalisations and health visiting. There are more outcomes available in the GUS than the IFS, and some are the same outcomes on both. So the idea is that we can be able to make statements about the generalisability of the wider GUS results based on the results that we have in both IFS and the Growing Up in Scotland study. We're examining a range of outcomes related to child growth, child morbidity, feeding patterns and maternal health, and each outcome relates to at least one of the aims of this scheme. For the primary outcome of vitamin use and breastfeeding initiation and duration, you can see that for all the comparison groups, there's no kind of difference in the proportion. So the first columns compare the recipients with the eligible, so the two green groups. The second column compares the recipients with the nearly eligible, so the dark green with the light blue, and the final column combines all the green, all eligible, so all the green, both the green groups, and compares them with the nearly eligible. And there is sort of slightly more breastfeeding initiation in the nearly eligible group, but it's not significantly different to the all eligible group, and there's not much difference really in the length of time breastfeeding. For child growth and feeding, outcomes, again, there are not many differences between the groups. There are slight differences with high proportions in the premature group for the recipients compared to the nearly eligible, and slight differences in the mean birth weight, but this isn't seen in the proportion of low birth weights. This is a slide for maternal health, and you can see stronger differences here with mothers in receipt of the Healthy Start vouchers having poorer physical and mental health measured by the SF12. And also you can see they've got higher proportions of smoking, but there's no difference in the alcohol use. And we looked at maternal financial strain, and there are no differences in the comparison groups in terms of managing the financials well, and also any financial difficulties that they may have. So in terms of strengths, we've used 2 control groups, and that allowed for 3 comparisons. And in the analysis, we used 2 different data sets. I just showed you the growing up in Scotland data in terms of time to day, but they were quite comparable in terms of what was found in the infant feeding study as well. But there are limitations. The propensity score matching is only as good as the matching process. And we know that the groups differ in terms of income, so we know that we can't match appropriately on income. We can still get nearest neighbour propensity scores, but they won't be a good matching in terms of income, because we know that that's the part of the eligibility criteria. And it would have been, better if we were able to use another method of analysis that might overcome that bias to assess the robustness of the results. But evaluating the health outcomes, it does have implications for policy. The Healthy Start vouchers had no effect in terms of improving vitamin use and breastfeeding and any of the other secondary outcomes. But our results do show that they're not detrimental for breastfeeding. One of the concerns about the Healthy Start Voucher Scheme and other kind of infant feeding schemes is that because they can be used for infant formula milk, there's an idea that they might disincentivise breastfeeding, but we showed that there didn't seem to be anything detrimental for breastfeeding. These results could also lead to recommendations for improving uptake in certain groups, which might help for reducing inequalities in the outcomes. And the qualitative study, which I didn't have time to go into the results today, that gives kind of like added evidence for this. Again, the Healthy Start voucher attempts to influence health behaviour, so as well as understanding policies in the early years, it can also inform if other policies that are aiming to change behaviour, and it also adds to the kind of like information about voucher incentives for behaviour change. Obviously, there are potential risks or harms to the population, as the use of the voucher can lead to more disposable income. You're displacing the income that you might be spending on something by using the voucher. So you might be able to then spend things on unhealthy items. And we were able to assess these health behaviours of the mother and found that there was an increase in smoking in both the recipient and in the eligible groups. So I suppose there are implications about needing extra policies to reduce smoking in these groups. And finally, I'd like to acknowledge the funders and the wider research group, especially Masood Borajerdi, who did most of the quantitative analysis, Susan Brown, who carried out the qualitative study, and Manuela Deda, who has been doing the health economics. Thank you.
Thank you so much.
I don't know if I've got time to do a shameless plug. Another project we've got at the moment. If you're interested in maternal and child health, we've got UK PRP funding to build a network using administrative data to evaluate national policy impacts on maternal, infant and child health. So please consider signing up to the network if you are interested in maternal and child health, and get involved in our prioritisation policies. So which policies should be prioritised for evaluation and help shape the research manifesto. Thanks, Katie.
Thank you so much, Ruth. That was a very clear, excellent presentation. Does anyone have a question for Ruth? Either just speak.
Hello, it's Danny White here. Can you hear me?
Yes, please go ahead.
Yeah, hi. Thanks very much, Ruth. Very clear presentation there. One of the kind of obvious concerns would be that as a result of your findings, policymakers will think there's no need to provide this benefit anymore because there's no evidence it's effective. Has there been any response like that?
So far, we've not had response by that. We did speak to some people in the Child Health Directorate at Scottish Government and talked about the results. And I was a bit nervous going there to talk to them about it, because it could be that they would then say, oh, great, we don't need to spend the money here, or we can spend the money in a different way. But, you know, they were keen to sort of point out and make the point that actually, although it might have higher rates of smoking, it means that they need to do something extra about the smoking rates in these groups. So it highlights that. So they weren't, the language certainly wasn't about removing this as a benefit. It was about how can we improve, you know, what's going on and how can we improve the outcomes. There's obviously a will in Scottish Government to, you know, spend in the early years. They've brought in the baby box, they've revamped the kind of early years payments in Scotland with the Best Start in Life, the way that they're sort of changing payments to families. They've got 3 payments at birth, starting sort of like early years, maybe age 2 to 3, and then again when they start school. So there is a kind of will there. So I don't think they would be looking to remove it. And I wonder as well, there's a kind of history of the scheme coming from the welfare food policy, or the welfare food scheme from the sort of Second World War milk tokens. And certainly the qualitative interview study that Susan was involved in, the kind of the results from that was definitely around the mothers really like appreciating the scheme and appreciating the value of the scheme. And so it might not necessarily show in kind of like hard health outcomes, but they certainly appreciated, you know, being able to sort of spend the vouchers on a kind of like range of fruit and vegetables that they might not have done in the past. So like now they were able to say, well, I bought a punnet of strawberries, and if they didn't eat them all, then that was fine. But, you know, I used the vouchers to buy that. But it gave them the opportunity to try a range of foods. So I think, you know, that would be something, you know, other ways of showing the benefits of the scheme.
Yeah, my recollection is that what Susan found was one possible interpretation of why it wasn't very effective. Well, there wasn't evidence of effectiveness, was that there was very poor understanding of what constitutes nutritious food.
Yeah, I think there was that as well, that, yeah, there was kind of, the mothers wanted to provide good nutrition for their children, but they weren't very sure what that was, or it wasn't really shaped very well as to what it was. So again, that would be something else to draw out, that it, you know, maybe it needs to come with a little bit more than just the vouchers. It needs to come with, you know, other things that show what is good nutrition.
Mm-hmm.
Thank you. Beverly, you've got your hand up.
Thank you very much indeed. Thank you for that extremely interesting talk. The children are now about 11 years old. Are there any plans to do a long-term follow-up?
We don't have plans to do a longer-term follow-up analysis. The Growing Up in Scotland study itself, that keeps going, and so there is information available on the children older, and also it can be linked to the health data, so we can look at, you know, at hospitalizations. But as I say, we don't have any plans to do that longer term analysis. But if anyone would like to talk to me about it and want to put in a funding bid for it, then I'm happy to advise them, possibly work with them.
Gerald, you've got your hand up.
Sorry, my name's Jude Robinson. I'm sorry, I'm on a home laptop, so I've got a very strange identifier. Ruth, a really lovely talk. And just to return to the smoking behaviour, was there any sort of further details? Because smoking status on its own doesn't necessarily tell us very much about the child's health, in terms of whether that was maternal smoke, whether they smoked during pregnancy, and also whether they're smoking outside, of course. And of course, there could be another smoker present in the household and the mother non-smoking. Do you have any sort of context around that?
I would need to go back and look at growing up in Scotland. This was certainly like maternal smoking. So it was the question what would be about like right around maternal smoking during infancy. I'm not sure we had maternal smoking during pregnancy. So it would be so it was really about the mother's health, as well as obviously it will impact on the child's health. But that was more about the mother's health in terms of the displacing of the income. So you might think by giving someone a voucher, that's better than giving someone money because the voucher has to be spent on a certain thing, but actually you're displacing the income that they might be spending. So they might have spent £3.10 on fruit and vegetables, but now they can spend the vouchers on that and they have that £3.10 in cash. So it's trying to think about the unintended consequences because you're displacing the money that way. But we didn't look, well, I don't recall, but I can go back and, because that might be interesting to see if we did have information on other smoking in the household and how that might impact on the child's health.
And the mother's health, of course, as well.
Yeah.
And just to say as well that it is quite a complex argument to say that they would have spent that money on fresh fruit and veg, but cigarettes often come first in budgets, so they probably would have smoked but just not had the vegetables. So I think it's a very strong argument to keep the vouchers.
We did do a little bit of work around that as to what they might be spending their money on and what they might not be spending their money on, but it wasn't, we didn't quantify that. Thank you.
Thank you so much, Ruth, and thank you to the questions that we got there. I'd now like to hand over to our second speaker, who is Dr. Karen Wetherall, who hopefully will be able to share her screen with us shortly. Karen's going to be talking about the mental health and well-being during the COVID-19 pandemic. And this is a longitudinal analysis of adults in the UK COVID-19 mental health and well-being study.
Okay, thanks, Katie. Can everyone?
Yeah, but we can see all your slides. I don't know if you want to move.
Okay, yeah, I'll do the full share in a second. I just wanted to make sure that it was definitely working before I did that. And can everyone hear me? Because I've been having numerous IT issues today. So
no, you're sounding good. So take it away.
Okay, great, thank you. Okay, so is that shared okay? Yeah, great, okay. Okay, well, thanks for having me today to have a wee, just an overview and a chat about some of the research we've been conducting during the COVID-19 pandemic. So we've been looking at the mental health and well-being of people across the UK over the last year, roughly. So just to put it into context, if we go back to the start of the pandemic, obviously it was a very novel and quite stressful time. And there was at that point a drive for research and for people to kind of monitor the mental health and well-being, a bit of a call to action. And within this paper, within the Lancet Psychiatry, there was one of the actions that they have suggested is to improve monitoring and reporting of the rates of anxiety, depression, self-harm, suicide and other mental health issues during the pandemic. And in addition, a systematic review that came out during the pandemic that was conducted by some of the people within our research group. It concluded when it looked at previous public health emergencies, and although obviously there's in our lifetime never been anything quite on this scale, in the research that had been conducted, they did find that there was an association between pandemics and an increased risk of suicide-related outcomes. And again, they highlighted the need to investigate this in relation to the COVID-19 pandemic. And that kind of puts into kind of context, I suppose, the study that I'm going to talk about today. So I was part of a group of researchers and stakeholders that came together right at the start of the pandemic. to try and kind of quite quickly develop and design some research to do just that, to really monitor and track the mental health and well-being of people. In this situation, obviously across the UK was the sample that we've looked at. And those research stakeholders weren't just from Glasgow University. There was researchers from Edinburgh, Leeds, Nottingham, and other mental health stakeholders, obviously including SAMARITANS, SAMH, and the Mindstep Foundation, who thankfully provided funding for the research to go ahead as well. So I'm going to talk a wee bit now just about the initial findings from the research, and in particular the findings from the paper that we published just towards the end of last year, that tracked really the health and well-being over the initial kind of 6 weeks of the pandemic. So just to give you a wee overview of the timeline, and I suppose bring us back to that period in time, although I know not many people would want to go back. We entered lockdown at around the 23rd of March, and the first wave of the study began on the 31st of March. And then the following 2 waves were over the next 6 weeks of the pandemic, with the third wave finishing just kind of around the start of May. And then just after that, so that was really during the kind of full lockdown, the first lockdown. And then after that into May and throughout June, there was an easing of the lockdown measures. So as I say, the findings that I'm reporting now are really during that first period. Just a wee overview of the actual study itself. So we recruited a nationally representative sample of adults from across the UK, just over 3,000 people in total. And it was based upon quotas. So we actually had a market research company, Taylor McKenzie. They did the recruitment for us, and it was based on age, gender, and socioeconomic status. The initial plan was to conduct around 7 follow-ups over the year. So we have actually conducted the 7th, and that was roughly kind of February this year. And we are actually about to launch an 8th, so we have actually got an extension on that. And we asked people questions online about a range of kind of mental well-being outcomes. Obviously, it was all conducted online. And that included symptoms of depression, anxiety, suicidal thoughts within the last week, feelings of loneliness and defeat and entrapment. So that's just a quick a kind of overview of where people were in the UK who took part in the study. So obviously most people based in England. About 11.5% from Scotland, 4.5% from Wales, and 2% from Northern Ireland. So just to kind of have a wee snapshot, first of all, now obviously frustratingly and unfortunately we don't have pre-pandemic figures for people's mental health and well-being. So we can't ever obviously say for sure that these figures have increased or decreased since or higher than they would have been before. But a kind of snapshot of how people were at the very start of the pandemic. So this is that kind of initial wave 1, just after the lockdown. So we found that around 1/5 of people reported that they had at least moderate anxiety symptoms. 1/4 reported at least moderate depressive symptoms, and about 8% reported suicidal thoughts within the last week. So having a look at how those mental health outcomes changed over time, we found by and large that most of the kind of mental health outcomes improved over the waves. So there was a bit of an initial kind of peak of maybe anxiety at the start, and that kind of tended to reduce over time. And certainly anxiety was one of the kind of more clear examples of that. Where by wave 3, around 17% of people reported having moderate to severe anxiety symptoms. We found a similar trend with depressive symptoms, but that trend wasn't actually statistically significant. And similarly, we found that levels of defeat and entrapment also decreased over time. Again, probably reflecting that initial kind of shock of the lockdown, shock of anxiety related to the pandemic itself, and that kind of uncertainty maybe starting to dissipate a little bit over time. But interestingly, we found that suicidal thoughts actually increased from wave 1 to wave 3, and which obviously kind of goes against the initial findings that we found for things such as anxiety and defeat and entrapment. And I mean, we can't know for sure exactly why there is that difference between suicidal ideation and the other outcome variables. But I suppose a couple of thoughts that we've had around that could be that there's maybe been a wee bit of a lag period. You know, that initial kind of peak anxiety and mental health symptoms that people felt at the start has maybe just taken a little bit of time to translate into kind of suicidal feelings. Or alternatively, it could be to do with how suicidal thoughts are kind of asked about, because suicide by its nature is a future event. So because there's a lot of uncertainty in the future, that could also be why, as compared to depression, anxiety symptoms, we ask about how people felt in the last week or 2 weeks. Maybe because the suicidal thinking is more in the future and people see a lot of uncertainty in the future is another potential explanation. So how do we look at this by different subgroups as well? Now, by and large, we found that the youngest age group reported the highest mental health issues, highest anxiety, highest depressive symptoms, highest defeat and entrapment. And again, similarly with suicidal ideation, around 14.5% by wave 3 report having experienced suicidal thoughts in the past week. And similarly for gender, we found generally actually that women reported, as with most mental health research, that women reported higher rates of things such as depression and anxiety. And here, obviously, suicidal ideation is slightly higher for women as well, but that difference actually isn't statistically significant. And as expected, the lower socioeconomic groups tend to be the most at risk for most mental health outcomes, and here for suicidal ideation, consistently reported higher rates. Although we did find, interestingly, that it was the high socioeconomic group that reported the bigger increase in suicidal thoughts across the waves. And again, that may be related to the kind of increasing financial uncertainty and I suppose that most people were facing during that time. And similarly with mental health condition, we found, as you would expect, that people with a pre-existing mental health condition did report much higher rates of suicidal thoughts within the past week. But again, those with no pre-existing mental health condition did report a slight increase over the waves. And then when we looked at loneliness, when we looked at the whole sample, there was no change in loneliness over time. But when we looked at it by age group, we found that there was a bit of a change, and actually that the youngest age group reported that their loneliness decreased over time. So that is a kind of overview, I suppose, of the findings from that paper. And the conclusion that we made was that the mental health and wellbeing of the UK population did appear to have been affected by that phase of the pandemic. And I suppose, although some of the mental health outcomes did significantly decrease over time, and there was that kind of trend, the increase in suicidal thoughts was of kind of particular concern. So now I'm going to go through some of the preliminary findings from waves 1 to 7. Now these haven't actually been published yet, so obviously we do ask that you don't share them with anyone at this stage. And just to give you a wee bit more of the timeline of when the waves 4 to 7 occurred. So waves 3 and 4 were kind of, or sorry, 4 and 5, sorry, were over May kind of to August. So that's really around the time that the restrictions that were happening around the UK were starting to ease. So really just during the summer when we could actually start doing things again. And then wave 6 occurred at the start of October, and that was kind of started to coincide with restrictions increasing, and certainly in Scotland and around the central belt there were restrictions on hospitality and how many people that you could see, and in England there was the tier system was introduced around that time as well. And then wave 7 again was February, and then kind of went into a full lockdown. Okay, so during this time, I thought we'd have a kind of look at how suicidal ideation progressed. Now, some of the numbers are a bit different from those reported before, because these figures actually just include everyone who has completed all the waves. So obviously we had that initial increase at the start, but we did find that suicidal thoughts kind of leveled out as the waves progressed, and certainly there was no difference between the later waves, and they all kind of sat from around 9 to 10% of people who said they'd had suicidal thoughts in the past week. But when we looked a wee bit closer at the different subgroups, we found some evidence that actually for younger people, there was an increase from wave 6 to wave 7 in suicidal thoughts. And obviously that's one of the groups that I suppose people have been most concerned about during this period. And we also find that for people without mental health problems, obviously people with mental health problems consistently had higher rates of suicidal thoughts during the pandemic. And as you can see there, that kind of fluctuated over the year, but stayed relatively high. We actually found that people with no mental health problems, actually their rates of suicidal thoughts steadily increased over the waves. And again, that probably comes down to that increase in uncertainty that people were experiencing during this time. Even whenever things eased a bit, there was always uncertainty as to what the kind of future would hold. And then with depressive symptoms, we did find an increase really to wave 7. So we noticed that kind of initial decrease from wave 3 to wave 4 and 5. But then by wave 7, there was an increase again. And here wave 7 is significantly higher than wave 4. But with anxiety symptoms, there was a bit of a decrease, but we didn't notice any significant increase. And interestingly, we found that both feelings of defeat and entrapment, similarly, they decreased those kind of when the restrictions eased around wave 4 and wave 5. And then there was an increase by wave 6 and wave 7 as the restrictions started to increase again. And we found that, we found that as well, loneliness increased by wave 7 as well, and that was kind of quite consistent across all the age groups. So obviously there we've kind of given a bit of an overview of how things have been kind of progressing with the study, and there does seem to be a bit of a coinciding of mental health outcomes increasing during when the restrictions kind of ease and go up again. And obviously this initial increase in suicidal thoughts that seems to have kind of steadily or kind of plateaued for the rest of the waves. But I suppose what I thought is a kind of have a wee look and see, well, what evidence is there to say that this is having any impact on suicide and suicidal behaviours? Obviously looking at other research that other groups have done. So a paper has been published looking at data from 21 countries. And I suppose at this stage, kind of reassuringly, they found that there's been no increase in suicide rates, and that there has been, certainly actually at the very start of the pandemic, there was even evidence that there was actually a decline in suicide, and I know that's been the case for self-harm. There's some evidence for that. But I mean, a lot of these countries obviously are high income countries, so obviously we haven't got the full kind of range of evidence just yet. But they do, the authors of this paper obviously do highlight the need to be vigilant and to be poised to respond to the situation, obviously as the mental health and economic effects of the pandemic kind of unfold over time. And then a very, very recently published study has actually has conducted a meta-analysis of all the research obviously that's been done so far. And they found 54 studies, actually including our study, which to kind of break down and see, do they have any evidence of any increases compared to, I suppose, the rates that there would be pre-pandemic. And they actually do, they find evidence that there is increased event rates of suicidal ideation, suicide attempts, and self-harm over this period if they consider them against kind of pre-pandemic event rates. And they find, similar to our kind of findings, obviously, they find that young people, females, and actually people from democratic countries, that has an impact on suicidal behaviour. So they find a number of moderators of that effect as well. So actually, overall, they're finding that it does seem that these suicidal thoughts and behaviours are increasing, but as yet we haven't seen a direct impact on the actual rates of suicide across the countries that have obviously the figures for that. So just to conclude, yeah, so it does obviously appear that the mental health and wellbeing of people in the UK have been affected in the initial phase of the pandemic, and obviously beyond that now, when we look at the kind of recent lockdown that we've been in. And the subgroups that we've kind of highlighted in particular that have been at risk are young people, women, people of a lower socioeconomic group, and those with mental health problems. But obviously, interestingly, we have seen increases in rates of suicidal thinking in people with no mental health problems and people with the higher socioeconomic group. So obviously everyone is at risk as well. And obviously rates were kind of highest for depression, anxiety, etc. at the start of lockdown, and they do tend to have steadily decreased as restrictions eased, except for suicidal thoughts. And although there's initially no evidence of an increase in suicide, obviously the increase in suicidal thoughts is concerning, and definitely you know, there is a need to be kind of vigilant and to monitor that. So yeah, that's.
Thank you so much, Karen. That was a great overview of some very important and interesting work. Do people have questions? Yes, Jim's got his hand up.
I was just clapping, actually.
Oh, sorry, I'm not good at my. Oh, well, you might like to just say well done then, I don't know.
Yeah, absolutely, that was an excellent presentation. Thank you, Karen.
Thank you. There's a question in the chat, Karen. I don't know if you can see that. Oh, then there's someone with their hand up as well. Who's got their hand up?
think it's Kate.
Oh, sorry, Kate. Oh. Sorry.
That's okay. Karen, thanks. I really enjoyed that. I enjoyed both presentations, so thank you. We've heard a lot, there's a lot of debate about the resilience of school children. I know you weren't looking at school children, but also of young people, and that, you know, that things will be all right and they're coming through sort of lockdown and the pandemic period and will kind of bounce back. And I think this shows a worrying trend that actually that's potentially not the case. So how do you see yourself as a team using these results to try and sort of negate some of the more sort of optimistic views about the impact on our young people?
Well, I mean, so we're actually running another study. We're looking specifically at Scotland, and that's actually with the Scottish Government, and they've been particularly interested in how young people have been progressing. So I suppose we're kind of hoping that if we can communicate that actually young people aren't progressing in the way that people hope, and actually their situation is tending to actually get worse rather than better, and actually they're doing objectively worse than other age groups and other populations. I suppose our hope is if we can communicate that to governments, to obviously the Scottish Government in that example, that they can take that on board and try and mitigate those risks and try and improve the situations and try and actually create more of a support and a kind of, I suppose, put in place. Like, I mean, when we talk about schools and all the uncertainty about exams and so many things that, I think young people have been, impacted much more than a lot of other age groups have in their prospects. So if they can put in place mitigations for that, then obviously that would be our recommendation.
Any final other questions or comments for Karen? No. Okay, I see that there's a comment in the chat, Karen, that you might want to have a wee look at. But if I just finally like to thank our two speakers, to Karen and Ruth. That's been a really excellent session. Thank you. And this concludes the cross-theme seminars for this year, but we'll start again in the next academic year. And thank you all for coming. It was a great turnout. Thanks. Bye, everyone.
Okay.